Hi, good evening, all. Um, this is the third session of my Udemy's training program for orthopedic related conditions. And today we will be discussing about knee, its related injuries, not the fractures and dislocations, but the, the ligament tears, the meniscal tears, then regarding other muscle related injuries that can happen in that area, plus OA knee in detail. Now, knee, we all know it is the largest joint in human body. And knee is a joint formed by three major bones. One is femur, then the tibia, and then we have the patella as a stabilizer in it. Now, fibula doesn't play a part in the knee joint, so keep that out of the equation. But these three bonds play a very important role in maintaining the normal day-to-day activities of a person. To move around, we need the knee. It's a weight-bearing joint, but a joint which is highly exposed also. Because almost all the parts of knee or the body prominences, everything we can palpate with the help of, we can palpate. And any of the tendons that are present in that area are very minimum. Remember that part. So majorly supported by the ligaments. So we have four major ligaments at the knee area, which stabilizes the entire joint. The major ones are the ACL, anterior cruciate ligament. Then we have the posterior cruciate ligament or the PCL, which prevents the posterior translation of tibia. The other one, anterior translation of tibia over femur. Now, and the two medial and lateral collateral ligaments. We call it the fibular or the tibial collateral ligaments that prevents the valgus and varus deformity. Now, in detail, we will be explaining about these ligaments, the test which we can do. We will have a demonstration of those things also. And it is bare minimum required in our clinical practice to get an idea, to have when a patient comes to you with an injury, any trivial injury is enough to have a ligament injury. And in such cases, you will be able to do a clinical assessment then and there before going for any of the investigations, which are radiographic investigations that can be cumbersome on the patient many a times, especially if you are practicing in a village area. You need these clinical skills to get in confidence about the patient's condition and say clinically then and there make a diagnosis, helping the patient in much better way. Or the conditions, if you are not able to manage, at least you can guide them to a proper orthopedic surgeon so that they can do the proper management of the patient without making the patient run around doing multiple tests or maybe treating them for long. And once the condition is worse, the which irreplaceable changes happens to the patient's joint. So such blunders shouldn't happen in the initial years of clinical practice. And I hope this class will help you in those details. Now, whenever a patient comes for a doctor's opinion regarding any of the knee-related problems, usually it will be either a chronic condition or it will be an acute condition. An acute condition can be because of multiple reasons: a slip and fall, a slip on the stairs, hitting directly the knee, the slipping and falling down, preventing the fall. You will hit the knee and fall down, and multiple injuries can happen, including bursitis, suprapatellar, or any of those bursas in or prepatellar bursas in that area can get injured. And there can be serious injuries like fractures also. Please make sure fractures we will be dealing in an entirely different session. Let's start with examining the knee joint tendons mainly. As you can see, the entire anterior compartment of the thigh, we have the quadriceps muscles, correct? Na? This is the important set of muscles we call as the quads. We have the rectus femoris, we have the vastus lateralis, we have the vastus medialis. Then see the bulk of the muscles also, and remember vastus intermedialis lies below the rectus muscle, so that is not visible. Now, this forms our quads muscle, and it is very important in maintaining the stability of the knee, as it is the tendon. In the tendon of this muscle, we have the patella, the sesamoid bone, the largest sesamoid bone in human body lies in that tendon only. And remember, after that, it becomes the patellar ligament that comes and attaches to the tibial tuberosity. Now, this will give you a clarity on the major tendons in the anterior part. Now, medially and laterally, we have other tendons that run. We have the sartorius that comes across and crosses over, but all those tendons doesn't play a major role in maintaining the knee stability. But another point you need to remember is on laterally we have the iliotibial band. This is an important part. The iliotibial band, remember the one that starts from the outer lip of the ilia crust and runs down, forming the bands of rest of the muscles in that area, forming a very thin band on the lateral aspect of the thigh, and it runs down and comes. And it also plays, this iliotibial band also plays a very important role in maintaining the stability of the knee. At this point, I want you to remember about the anatomy of the patella, also the posterior surface, which has the bony prominences and plus the muscle insertion, the tendon insertions that prevent the dislocation of patella. Remember that one also. And the movements of patella while we do the flexion and extension of the knee. Please remember, you can do on your own a flexion extension, and you can examine how the patella moves inside your in your body also. Now, this will give you an idea of the entire knee related tendons. Now, we will be moving on to the next set. That is, we have the ligaments of the knee. Now, the major ligaments of the knee, we call the first one is the anterior cruciate ligament. You can see how the cup shaped it goes and attaches to the posterior aspect. Now, to the posterior cruciate ligament, that prevents the anterior translation. Now, preventing the two valgus and varus deformities are the lateral collateral ligament and the medial collateral ligament. These are the major ligaments of the knee joint. Plus, here in the on the articular surface of the tibia, we can see a C-shaped cartilage, correct? Now, this is known as the meniscus. We know the medial meniscus and the lateral meniscus. This one is the lateral one and this one is the medial one. And remember, these are C-shaped. And whenever any tears or anything happens, usually it is happening in this meniscal. Footballers usually will get, we call it the bucket handle tears. We can have flap tears also. The meniscus. Remember that it can have the flap tears, like two flaps. It can tear off like this. This is what we call the flap tears. And flap tears are all notorious, which we can't manage only. But rest of the tears, if it is very minimal, we will be able to handle. Otherwise, meniscal tears are very difficult to manage with the Ayurvedic principles. So this will bring to an end to the anatomical aspect of the knee. Okay. Now to the examination of the knee. Today I'm thankful to Ashwin being here so that I will be able to demonstrate examinations on his knee. See, one of the reasons why he was selected, because he had earlier multiple injuries with his left knee, and it was dislocated also once. And just whenever we do any joint examination, the base rule which I see is look, feel, and then move. Look, feel, and move. First thing, looking at the joint, inspecting the joint itself, you can see there are multiple traumas. You can see a scar point here, another scar point here. Now, these are injuries that he had over a period of time, grievous wounds that he had, maybe a fall from a motorbike, or maybe fall from stairs or any of those injuries, because these are injuries of long run. And see, not like other areas of the body where it will be easily vanish after a few years of time, but this ones will remain. And this is one of the best clues whether the knee has undergone trauma or not. We will be able to, these are all serious injuries. You can clearly see the visually see. When we are seeing the joint, we can see a medial gutter, we see a lateral gutter. And remember, these two gutters are very important. Now, this is a very lean knee, that's why these two. But if it was a fat person, definitely there would have been a fat pad above, maybe a fat pad on the side. So we can have maybe gutters here and here, but those are not actual ones. The major ones are the medial ones and the lateral ones. Remember, when a patient comes with an OA knee, our point of interest will be on the medial gutter, where we will be seeing the joint line, where we will be able to examine the joint line between tibia and the femur. Now, this is with the look part. Now, the next thing we will be seeing is the feel part. First thing is feeling the temperature, whether the joint is of normal temperature as the rest of the skin. If it is there, then we can solidly say that there is no inflammatory signs in the joint area, especially a patient with OA or rheumatoid arthritis or any other inflammatory this thing in the body. The joint will be definitely inflamed. If the joint is inflamed, definitely it will be on a higher temperature note. Remember that one. The temperature part. The next one we need to feel is the quadriceps tendon. Ask the patient to make taunt of the muscle, and we can see that, yes, please make the taunt. And you can see the way the patella actually like it just started to ready up, or maybe it is like in a attention position. The patella came in with the quads getting like a tone of action given to the patella, and the patella is ready with with the patellar ligament, everything toned. So this is patella in a ready position, or in a weight bearing or a loaded position for the quads, that you have to regularly check. Many a times what happens, if the quads are weak, you will see the patella sluggish in many a times. Another thing you have to do is the medial and the lateral movement of the patella, whether the patella is mobile, whether the patella will move upwards or backwards. In his case, he had an earlier patellar dislocation, and that is clearly visible with the slip, actually, with the slip happening to the patella. Okay, now the next thing is the move part. The move part, which we already started, but the normal range of movement. We have a flexion, which all of you know, and we have an extension. Now, to going into the further examination of the knee, we have a set of specialty tests which we call for ACL, PCL, medial and lateral collateral ligaments, and the menisci. And with this, we will conclude the today's session. So individual specialty tests. So with the test continuing, stability test continuing, basically we have the anterior drawer test, the Lachman test, then we have the posterior drawer test, and finally we have the valgus stress and the varus stress. To valgus test to check for the MCL or medial collateral ligament, and the varus stress to test the LCL or the lateral collateral ligament. The first one we are going will be the anterior drawer test, which I will be demonstrating right now. Okay, the patient should be in a the knee should be flexed to 90-degree, remember, and the doctor will be sitting on the foot of the patient so as to stabilize. The weight of the body will be stabilizing the thigh area, and the weight of the doctor will be stabilizing the lower part of the. Now, with both hands, we are going into the two heads of the gastrocnemius muscle on the medial and the lateral aspect, and the thumb in stabilizing the tibial tuberosity. In this position, our main aim is to pull the tibia forwards. If there is a slight movement of tibia on the femur, if there is an anterior translation of tibia on femur, that shows that there is a lax. And usually for that, with a skin marker, we will be doing at the joint line, we'll be doing a straight line on the skin between the femur and the tibia through the joint line. And then if we pull it, we can see that if there is a laxity, there will be an anterior translation happening, and that will give us a clue. And further gradings can be done based on the amount of grade 1, grade 2, grade 3, and all that can be said with the help of this one. Remember, it's the translatory movements that happens, and that is the case. That is the ACL test. Now, the Lachman test, it's a more sensitive test for the ACL injury. Patient will be in supine position and the knee will be flexed at 20 to 30 degree. This much only is enough, 20 to 30 degree. Stabilize the femur with one hand and pull the tibia towards the other. Now, we will be stabilizing the femur with one hand and pull the tibia with the other, like stabilizing and pulling. And as a result, there will be a translation. Now, this will be a very minimal stress on the joint. Remember the Lachman test. Whereas the ACL, you will be putting the entire force. But in this one, what we will do, we will be just doing the opposite. From below, I will be pushing up. Above the thigh, I will be pushing downwards. And we will see any translatory movement happening. Now, excessive forward translation of tibia, we have to compare it with the unaffected side, and we will be determining whether there is a ACL tear or not. Now, the second test is the posterior drawers test. It is done the same way as the anterior. Now, the patient's position is supine with the leg or the knee flexed. And then what we'll be doing is we will be pushing the tibia. The position of the hand will be the same on the gastrocnemius toe side, on the tibial tuberosity, and then we will be pushing it backwards. Now the pressure is towards the patient, and the same translation happens posteriorly. Then it shows that our posterior collateral ligament is torn. Okay. Now the next one is the varus and the valgus test. Now the valgus stress test. Now, usually it is done with the knee flexed. Now, what you will be doing, you will be giving because our test is the medial collateral ligament. Medial is this one. What we will do a valgus stress. Now, when the valgus stress is when the knee will be put like a stressed like this. Now, in that case, what will happen? In valgus stress, if there is too much happening, it shows that the medial collateral ligament is affected. Now, if it is the opposite, the reverse one that happens, if it is the varus stress, now this joint is very typical, and there is a little bit of valgus and varus stress test positive in this one because of the hyperflexibility of the ligaments. And he is a case of genu recurvatum, and that I will show you right now. You can see that. See, classically this is very rarely we will find, and he doesn't have any problem or anything, but this condition is known as genu recurvatum. The way you can see the amount of posterior translation or hyperextension the knee can do, this is not normal in other individuals, but for him it is perfectly all right. He doesn't have a problem. He doesn't have any other issues with this. This is just the ligament laxity that I want to demonstrate, and that's why the test, there will be a minimum amount of movement or translatory movements that you can get in this knee. Now we go into some special test. The ligament tests are over. Now the special test, the first one is for the meniscus, and it's known as the McMurray's test. Now it's usually used to detect meniscal tears. The method is with the patient supine. You have to flex the hip and the knee. Now the hip and the knee is to be flexed. Now hold the heel and rotate the tibia internally. Remember, hold the heel and rotate the tibia internally to test the lateral meniscus. Now this is done to test the lateral meniscus. Yes, now with this internally, externally to test the medial meniscus. Internally, externally. Now what will happen? We will be having a internal rotation, external rotation and internal rotation, and that's how the grinding happens, and that's in a way of getting the meniscus tested. Next test is applies grind test. Now, the position of the patient is in prone. The test is by flexing the knee to 90 degree, stabilizing the thigh. The thigh can be stabilized by keeping your knee also, or you can hold the knee. Then what you will, as the test name itself says, the grind. You will be pushing the knee down and doing internal and external rotation. If there is a meniscal tear, the patient will have excruciating pain, and patient will say that there is severe discomfort. The next test is my favorite with meniscal injuries. Any patient who comes to me, I'll be doing this test only. For me, McMurray is because each doctor is based on their practice and all those things. They will have their own test for individual things, individual examinations clinically to do. And which the test which I usually follow is Thessale test. Now the test is done like this. We'll be asking the patient to stand on one knee. Usually, I will ask the patient to stand on the unaffected leg initially to have an assessment for the patient to understand. Now, what will be? You can see me standing with a weight bearing on one knee joint, and then I will ask the patient to do a rotatory movement. This torsional movement at the knee itself is enough. Even if minutest of the injury is there, then definitely the patient will have. Now there is an advanced stress test to this one. We will ask the patient to do a 20 degree or a 15 to 20 degree of bend of the knee. Now the weight bearing of the knee joint or the stability of the knee joint is excruciatingly tested. The menisci has to be very strong to keep the knee in this position. And here again the stress is applied. Now even if the patient is having with the normal stress, if the patient was comfortable, but with this advanced stress one, the patient will have definite and excruciating pain if they are having a meniscal injury. And this is one of the major tests which I do. With this, we come to the end of our session on knee examinations and all. The regarding Banda and all those we will discuss on our offline class that will be happening on the 20th. And hopefully see you guys on 20th of May.